Hi everybody, we're group 4 and we did our presentation over neurogenic and spinal shock.
So with the left, we're starting off with neurogenic shock. This occurs with the high spinal cord injury, typically above the level of T6. The main problem is the loss of sympathetic tone, which leads to low heart rate and low blood pressure. That is bradycardia and hypotension. Because of the loss of catecholamine like epinephrine and norepinephrine, the vessel dilates, causing the hemodynamic collapse. This type of shock directly affects autonomic function, not just the spinal cord itself. So some examples are cervical spinal cord injuries and sometimes severe traumatic brain injuries. On the other hand, spinal shock can occur with any level of spinal cord injury. It doesn't have to be high level like the neurogenic shock. It's a temporary loss of all reflexes, motor function, and sensation below the level of the injury. However, unlike the neurogenic shock, spinal cord doesn't cause hemodynamic changes, so it doesn't directly affect the blood pressure or the heart rate. The underlying issue is the disruption of reflex and descending pathway in the spinal cord. For example, it could be spinal cord compression, ischemia, or infarction. Now, both neurogenic shock and spinal shock results from damage to the spinal cord. They both involve a loss of neurotransmission below the level of the injury, which means patient can experience paralysis and loss of sensation. In both conditions, immediate spinal immobilization and support care are key to preventing further injury.
Spinal shock is a temporary loss or impairment of spinal cord function below the level of injury, and it typically occurs after an acute spinal cord injury, which is most commonly caused by blunt force trauma, such as motor vehicle accident, bikes or pedestrians, falls, especially in older patients, or penetrating trauma, such as gunshots or stab wounds. Spinal cord injury can also be a result of mechanical damage, metastatic disease, abscess formation, or ischemia. As I said, spinal shock is a temporary impairment of spinal cord function. If the neurologic impairment is permanent, it is due to the underlying spinal cord injury rather than the spinal shock itself. 55% of spinal cord injury occurs in the cervical region, with cervical spondylosis being the most common risk factor. And there's about 15 to 40 cases per million worldwide, and the majority of these cases are young men secondary to trauma. So in spinal shock, the initial presentation will be characterized by a loss of reflexes below the site of injury, and this is during what we could say is spinal motor neuron hyperpolarization. This usually lasts 0 to 24 hours. You'll typically see a delayed plantar reflex initially, followed by delayed abdominal wall and cremasteric reflexes. Phase 2 of spinal shock occurs after that first 24 hours, and there is suprasensitivity and receptor upregulation, basically just meaning that the nerves are in a state of increased responsiveness after the nerve supply is damaged, and the number of receptors on cell surfaces increase as a response to this lack of stimulation. This typically lasts from day 1 to day 3, and you will start to see the cutaneous reflexes returning, such as the plantar reflex and abdominal wall reflex, but deep tendon reflexes are still absent at this point. Phase 3 spinal shock can last between 4 days and 1 month, and is characterized by synapse and short axon growth, and this helps the deep tendon reflexes begin returning. And then phase 4 is the final phase and can last up to 12 months, but it's characterized by long axon growth and more synapse formation, and you will typically see some hyperactivity of cutaneous and deep tendon reflexes with even just minimal stimuli. And during this phase is where you might also see some autonomic dysreflexia. So to evaluate a patient for spinal shock, you will need to stabilize the patient initially and then evaluate for spinal cord injury. So, the typical ABCs and spine immobilization to prevent further injury. And then any spinal cord injury above C5 can typically lead to a loss of respiratory drive, so you'll need to assess for that. Any injury between C5 and T5 may have some ventilatory impairment, so you'll need to still carefully assess their respiratory status. Hypotension typically is present, especially if it's a thoracic injury above T6, and you'll see flaccid paralysis, absent reflexes, absent bowel and bladder control, complete loss of function below the site of injury. You'll want to complete a full physical exam, including a neuro exam, the patient history to assess for possible risk factors, history of injury, mechanism of injury, and any other medical history. And once that spine is immobilized and stabilized, you'll also want to do a complete and thorough inspection and palpation of the spine to try to identify the site of injury. Along with that, it's important to do Glasgow Coma Scale and the ASIA scale, and this is for spinal cord injury, and it's graded from A to E. It's done in the emergency room, typically right on presentation, but for patients in spinal shock, they will grade as an A because they will have complete impairment with no motor sensory function below the site of injury. And then once the patient's stabilized, you'll want to do a CT brain, spine, chest, abdomen, and pelvis to evaluate for signs of bleeding, to look for fracture, and better assess the site of spinal cord injury. MRI is superior to a CT scan, but these patients are often not stable, and that is time consuming, and is usually typically only indicated if they're needing further evaluation because the CT scan is unclear, or if there is surgical planning that's needed, then you would get an MRI of the spine. Treatment, once you identify the site of injury, is typically centered on mitigating damage and preventing complications, centered mainly around hemodynamic and respiratory management if compromise occurs. So maintaining adequate perfusion to the spine is crucial in spinal shock, and in patients that have that cervical and upper thoracic injury, they may require more strong hemodynamic support, and that would come in the form of norepinephrine, typically as the first line agent because it has fewer adverse effects than dopamine or phenylephrine. The MAP goal for these patients can often be higher. Greater than 85 for the first 5 to 7 days is often recommended in acute spinal cord injury. Midodrine and desmopressin have also shown to be beneficial in achieving this higher MAP goal in these patients. And need for careful fluid management to prevent overload and worsen respiratory dysfunction in patients that are requiring this support is important. And again, if they are having these injuries in the cervical or upper thoracic region, they often will require respiratory support in the form of mechanical ventilation. So then everything that goes along with preventing complications with mechanical ventilation, preventing ventilator-associated pneumonia, chest physiotherapy, deep suctioning, influenza, and pneumonia vaccinations. Glucocorticoid use is recommended by some, but it is controversial. The American Association of Neurologic Surgeons do not recommend using glucocorticoids, but AO spine guidelines recommend methylprednisone in the first 24 hours. Theoretically, it would help to reduce inflammation and edema around the site of spinal cord injury, but the evidence is generally pretty weak that it does promote better outcomes. Surgical decompression, however, has shown to provide better outcomes in areas where there is increased edema and inflammation. This can help prevent secondary ischemic damage from the spinal cord injury. And then other supportive therapies will be needed for all patients with spinal shock. If their injury occurs below that upper thoracic region, then this might be the only supportive therapy that they need. They might not need the hemodynamic and respiratory support, but this would include BTE prophylaxis, such as low molecular weight heparin and pneumatic compression, bowel and bladder management with bowel regimens and intermittent catheterization rather than indwelling catheter because the bladder function will return, pressure ulcer prevention and pain management, ideally with acetaminophen and NSAIDs rather than opioids due to their increased risk of respiratory depression, and physical therapy with these patients will also be important. Consulting neurosurgery is typical to see if there is any need for decompression, and especially if they have a spinal cord fracture, the neurosurgery will definitely need to be consulted to see if there is a surgical option. Physical therapy, as just mentioned, to help get these patients moving as soon as possible. Respiratory therapy, especially if they are ventilated. Registered dietitians to help with nutritional support in their recovery process. Pharmacy to manage a lot of the different medications they'll be on and screen for drug interactions. Registered nurses caring for these patients around the clock, and then social work, because even though the spinal cord impairment is temporary and they do regain function, they will often be quite debilitated and may need long-term rehab or assistance outpatient before they make a full recovery. In geriatric patients specifically, they are more likely to have developed an acute spinal cord injury from fall, so that will be important to screen when initially assessing the patient. They may be more likely to have functional or cognitive impairments at baseline, which can impact your physical exam, so needing to take that into consideration when determining if impairments are related to spinal shock or something that is present at baseline. These patients often will have decreased physiologic reserve, which can lead to prolonged recovery time, even if the spinal shock resolves. And they are more sensitive to medications and their side effects, particularly the medications that can be used for hemodynamic and respiratory support, as well as ventilation. Will be more difficult to wean them from the ventilator and can be more likely to develop complications down the line.
Now we'll be moving on to neurogenic shock. So for disease background and pathophysiology, we define shock as organ dysfunction from an imbalance between cellular oxygen supply and demand that results in cellular and tissue hypoxia. Distributive shock is a category that neurogenic shock falls under. It is a loss in sympathetic tone with a reduced SVR and hypotension without a compensatory tachycardia. So it results from the reduction in the systemic vascular resistance, leading to inadequate cardiac output and tissue hypoperfusion despite normal volume. For etiology, risk factors, and clinical manifestations, etiology can come from spinal or brain cord injuries. When it occurs in spinal cord, it typically affects the cervical and upper thoracic areas. It could come from spinal anesthesia, neuropathies, Guillain-Barré syndrome, and toxins. You have several risk factors such as trauma, like gunshot wounds and motor vehicle collisions, diseases that affect the spinal cord, alcohol and drug use, and heart disease. And it presents with hypotension accompanied by bradycardia, hyperdynamic heart sounds, widened pulse pressures, which are indicative of a large stroke volume. So neurogenic shock can be diagnosed with evidence of CNS injury and persistent hypotension despite volume resuscitation. Some diagnostics we can get are an echocardiogram, specifically a TTE. This can show us if there is a hyperdynamic left ventricle. We can get a CT of the spine to evaluate the structure and alignment issues, or we can get an MRI of the spine, which will give us a more detailed view of the ligamentous structures and abnormal cord signal changes. For labs, we can get our CBC, CMPs, and ABG, coagulation parameters, lactate levels. We could also get additional studies, bacterial blood urine, sputum cultures, and nasal PCR to rule out other potential causes. So for pharmacologic and non-pharmacologic management, we would use general measures to support airway, breathing, and circulation. You have mechanical ventilation with sedation. Mechanical ventilation, decreased respiratory bustle oxygen demand allows for improved oxygen delivery to the hypoperfused tissues. You could also use vasoactive therapy. Vasopressors are inotropes. If fluid resuscitation didn't help, fluid resuscitation is to address the vasogenic dilation of a typical neurogenic shock. So you would monitor strictly, as excessive resuscitation can lead to complications. Typically, norepinephrine is preferred as it increases the MAP over the cardiac output, and you would typically want to have a MAP greater than 65 for cardiac monitoring. And then also for cardiac monitoring, you can use an arterial line to monitor the blood pressure, and a central line for access to monitor hemodynamics and parameters.
So for the interprofessional collaboration and referral, we have neurosurgery team. They determine the level and the stability of the spinal injury and decide whether surgical decompression or stabilization is indicated. We also have critical care team. They play a major role in hemodynamic support for the patient, managing hypertension, bradycardia, and ventilation needs. They also coordinate ICU monitor and adjust intervention as the patient stabilizes. We have nursing. Nurse help provide continuous bedside assessment, monitor for autonomic instability and changes in reflex and skin integrity. We also have PT and OT. They are important to prevent contracture, maintain muscle tone, and assist with mobility and adaptive strategies. They also help the patient regain independence and improve long-term function. Pharmacists help manage vasoactive medications, optimize pain control, and prevent complications such as DVT or infections. We also have respiratory therapists manage mechanical ventilation, perform suctioning, and provide pulmonary hygiene. Social workers and case managers support both the patient and family through discharge planning, insurance coordination, and connecting them with rehab facility or home services. We have geriatric team, palliative team, and also multidisciplinary rounds bring everyone together daily to align the care plan. And we also want to integrate the family into discussions to support shared decision and long-term care planning. Geriatric considerations in managing the disease. When caring for older adults with spinal or neurogenic shock, we need to adjust our approach to account for age-related physiology change. These patients have reduced physiological reserve, making them more vulnerable to complications and slower to recover. So first, for the physiologic vulnerability, older patients have a reduced autonomic reserve, meaning their bodies can't compensate as effectively for sudden drops in blood pressure or heart rate. They also tend to have slower neurologic recovery, so improvement in reflexes or motor function may take longer after the injury. In addition, many have baseline functional or cognitive impairments, which can complicate assessment, delay rehab, and increase the risk of delirium. For hemodynamic management, we need to be cautious with fluid resuscitation to avoid fluid overload, especially in patients with cardiac or renal comorbidities. Older patients have increased sensitivity to vasopressors, so dose should be started low and titrated carefully to prevent excessive hypertension or arrhythmias. Lastly, in prevention of complication, these patients are at higher risk for delirium, so strategies like early mobilization, reorientation, and minimize sedative are important. We must emphasize pressure injuries prevention, since immobility and fragile skin make ulcers, especially in the sacrum, are more likely. And finally, consistent thromboprophylaxis is critical to prevent DVT or pulmonary embolism due to prolonged immobility.
So for this case study, a 28-year-old man presents to the emergency room after falling backward off his bicycle. He is complaining of mid-lower back pain and bilateral leg weakness. On exam, he is normal intensive, the blood pressure of 128/66, MAP of 87, and heart rate 89. He is noted to have 0 out of 5 strength in both of his lower extremities and absent plantar reflex. What are the most important next steps in terms of assessment, diagnostics, and intervention for this patient? So we are concerned for acute spinal cord injury secondary to trauma with potential spinal shock. So what do we do next? Big important things will be to immobilize the spine to prevent any further damage, stabilize the patient. At this point, he does seem stable in terms of his vital signs, but finishing the vital sign monitoring, checking his oxygen status. And once he is stabilized, we will get a CT of the brain, cervical spine, chest, abdomen, and pelvis. And this will provide a thorough assessment of the spine to assess for any fracture, edema, any injury from the fall, any need for decompression or surgery, and anything that we see that would cause us to need to consult neurosurgery. After the CT scan, before the CT scan, you'll want to inspect and palpate the spine to try and determine the site of injury, especially if it's not seen on the CT scan. Just looking for any obvious signs of trauma. You'll want to complete a complete neuro exam and patient history, and close vital sign monitoring will be important. At this point, his vital signs are stable, and all of his symptoms point to the fact that his spinal cord injury is likely in the lower thoracic region, which means he'll be less likely to develop hemodynamic instability like hypotension that he would in a case where he had an upper thoracic or cervical injury. And same with his respiratory capabilities. These likely will remain intact if indeed the injury is in the lower thoracic region. But these vital signs need to be monitored closely just in case, because at this point we do not know for sure where his spinal cord injury is located. With the spinal cord injury, we want the higher MAP, typically closer to 80, 85 for the first couple days to maintain adequate perfusion. At this point, this patient has a MAP of 87, so that's adequate, and he won't need to be started on any medication, but it's something that needs to be monitored in case that drops. And you will also assess for other things that go along with the spinal cord injury and spinal shock, such as lack of bladder control. So we'll assess for urinary retention. During the neuro exam, you also will assess his reflexes, and will likely expect to see absent abdominal wall reflexes and cremasteric reflexes as well.
So for question 1, a 45-year-old male presents to the ICU following a high cervical spinal cord injury. He is hypotensive with a MAP of 58, bradycardic at 42, and presents with warm, dry skin. Which of the following is the most appropriate initial pharmacologic intervention to manage his neurogenic shock? A. Atropine every 3 to 5 minutes. B. Phenylephrine infusion. C. Norepinephrine continuous infusion to maintain a MAP greater than 85. Or a dopamine to improve cardiac contractility. So the answer is C. Norepinephrine continuous infusion to maintain a MAP greater than 85. Which of the following hemodynamic findings is most consistent with neurogenic shock? A. Increased SVR and tachycardia. B. Decreased SVR and bradycardia. C. Increased cardiac output and hypertension. D. Elevated CVP and tachycardia. So the answer to question 2 is B. A decreased systemic vascular resistance and bradycardia. Again, when they're in neurogenic shock, they lose that sympathetic tone, so that is accompanied by a reduced SVR and hypotension without a compensatory tachycardia.
Question 3. A 60-year-old male with T4 spinal cord injury is admitted to the ICU with persistent hypotension despite fluid resuscitation. Which diagnostic findings support neurogenic shock rather than hypovolemic shock? A. Elevated lactate levels and cold, clammy skin. B. Hypotension with bradycardia and warm, dry skin. C. Narrow pulse pressure with tachycardia. D. Decreased urine output and delayed capillary refill. The answer is B. Hypotension with bradycardia and warm, dry skin. Question 4. During the initial management of neurogenic shock, which of the following interventions should be avoided? A. Gradual fluid resuscitation. B. Large volume isotonic fluid boluses. C. Vasopressor support. D. Cervical spine immobilization. The answer is B. We should avoid large volume isotonic fluid boluses. Question 5. A 35-year-old male is brought to the ED after a motorcycle crash. He is alert but reports loss of sensation below his chest and weakness in both legs. His blood pressure is 80/50, heart rate is 42, and skin is warm and flush. IV fluid are started, but his blood pressure does not improve. What is the next best step in management? A. Administer atropine IV and start norepinephrine infusion. B. Give 2 to 3 liter bolus of normal saline. C. Administer dopamine 10 for renal perfusion. D. Begin IV methylprednisolone to reduce spinal edema. The answer is A. Administer atropine 0.5 mg IV and start norepinephrine infusion.